each other a little bit. Thomas Hunt Morgan was an American geneticist and zoologist who died on this day in 1945, and he was very famous because he established the theory of chromosomal heredity. And he basically did a lot of work in Drosophila, and he found that certain genetic variations can be inherited together because the genes that control these variations are in the same chromosome. And he was the first to describe that. His team actually looked at a whole map, a whole set of genes in Drosophila. He published a very famous book called The Mechanisms of Mendelian Heredity in 1915. And his theories were not quite accepted initially, but later on they were, and he was awarded the Nobel Prize for Physiology of Medicine in 1933. But today is about the heart. And so I found that Robert Wallace Wilkins was born on this day in 1906. Dr. Wilkins was an American physician who contributed a lot of research on hypertension and cardiovascular disorders, and he was known for introducing into the United States a drug that was used in India for the treatment of high blood pressure. It was made out of the root of an Indian shrub. It turns out it was reserpine that had better use as a tranquilizer than as an antihypertensive drug. Because of his work and his efforts, he rose through the ranks and he became president of the American Heart Association in 1957, and the same year he was inducted into the American Academy of Arts and Sciences. With that, I will leave you with Dr. Roberto Bolli, the chief of the pulmonary division. He now runs the cardiovascular and the pulmonary division. And today he will introduce our speaker.
Thank you, Jesse. I'm pleased to introduce today our speaker, Dr. John Loughran. John graduated from St. George's University in 2006, came to Louisville, did his training in medicine here. Then for a year he went to the dark side. He was a hospitalist at Loughran, but he quickly came back on the right path and joined a fellowship in 2010. He chose to do a 4-year fellowship. So every given time we have 2 fellows that do 4 years instead of 3. Those are 2 of research and 2 of clinical training, and they do so because they're serious about becoming clinician scientists, and they want a thorough, comprehensive, and solid training in research to prepare them for academic success. So John chose that pathway and did extremely well. He was the driving force behind the CITO, the first in-human study of cardiac stem cells in patients with heart failure, which I'm sure he will discuss in his presentation. He worked very, very hard. We could not have done that study without his tremendous dedication and effort. In the summer of 2011, we spent many nights, John and I, writing the paper that was eventually published in the Lancet, and we were up until 2, 3, 4 in the morning, emailing us the drafts back and forth to get this thing out in the press. So he was recognized as the Research Fellow of the Year in 2010, the Research Fellow of the Year in 2011, and was Chief Fellow in a fellowship program, has contributed to a number of other research projects, and is now well poised to launch a successful career in the clinical science. Today he will discuss the issue of cell therapy and mending a broken heart.
Thank you, Dr. Bolli, for that more than generous introduction. I know a lot of people here, and
turn your microphone on.
I'm sorry?
Don't forget to turn the microphone on.
I'm pretty sure it's on. Is it on?
Yeah.
All right.
Just making sure.
You hear the voice. I'm not quite up to speed here, and that between that and the New York accent, we may need subtitles today. But beyond that, I hope to have a really good discussion here. I remember coming here 8 years ago and sitting in the back where all the trainees are and thinking to myself, what a daunting task to speak in front of this room of established clinicians. And for those of you who know my proclivity for public speaking or lack thereof, you'll know that 8 years has changed. Today I would like to talk about a topic that I have spent a good deal of time on over 5+ years in the cell-based therapies for post-infarction, left ventricular dysfunction. I have no financial disclosures. I am one of the co-principal investigators within the CCTRM, we'll discuss later, but I take no consultant's fees from that role. So today's outline, first, of course, as with every grand rounds, we start with the case, which we'll come back to intermittently throughout the presentation. Talk about what rationale for cell-based therapies, as well as the history of cell therapies for cardiovascular disease, with focus on the clinical trial data that we've garnered over the past 13 years or so. We'll talk about the pitfalls and concerns concerning that data, because that's most important for moving forward. So we'll get into discussion of future directions of cell therapy, especially concerning what we are doing here at the University of Louisville and how we're poised to move forward in the field. Case presentation, our patient came to us in 2009. It's a 65-year-old male with multiple cardiac risk factors, known coronary artery disease, that is post-MI in 1999. Presents with worsening symptoms of ischemia as well as heart failure. His echocardiogram shows an EF of 24% with an anterior wall MI. Coronary angiography demonstrates severe 3-valve disease. And a Valium scan was performed, which showed viability in the apical anterior wall. As such, coronary artery bypass surgery was performed without complication, but the patient's exercise tolerance is decreased to about 100 feet. He also admits to frequent nitroglycerin use, although symptoms are somewhat improved from pre-surgery. Now at 4 months post-surgery, he has a repeat echocardiogram demonstrating an ejection fraction of 26% with cardiac MR showing transmural infarct in the anterior distribution. So before we discuss what potentially our next course of action would be for this patient, I think we should discuss some of the statistics surrounding cardiovascular disease. Every year, the AHA comes out with an update on heart disease and stroke statistics. This graph represents the top causes of mortality in the United States. First column is cardiovascular disease. Second column is cancer, followed by trauma, chronic lower respiratory disease, diabetes, and Alzheimer's disease. And of course, the astute, I would say, well, you're talking about white males and females, but what I would ask you to do is over these next few slides that I'll quickly go through, take a look at that trend. This is for African American males and females, Hispanic males and females, Asian and Pacific Islanders, and American Indians. It's quite a striking trend. It's very, very similar across the board. And so if we look at the final numbers, what we see is that combined males and females got 800,000 deaths in 2010 out of the 2.5 million totals, equating to 1 in 3 Americans dying from cardiovascular disease during that year. So quite a burden on the healthcare system, as well as the families who are involved in the care of those patients. And when we break down the financial data of cardiovascular disease, also what we can see is that between coronary artery disease and heart failure, we spend an inordinate amount of money within the healthcare system. Very costly diagnoses translating to an overwhelming burden on patients, practitioners, and healthcare systems alike. There is a linear relationship between the incidence, prevalence of coronary heart failure, over the lifetime of an individual, and after age 40, the lifetime risk of developing heart failure is approximately 1 in 5. Interestingly, that drops to 1 in 9 without antecedent MI, intimating the relationship between the two disease processes. Currently, the prevalence of heart failure in the United States is estimated at about 5.1 million individuals, or about 2% of the population. And this is a proportion which is fairly steady across the board when you look at other countries, making this really heart failure is a public health burden on a global scale. This is hospital discharges for heart failure, and as you can see, over the last 20 years, hospital discharges for heart failure have increased by 250%. This is likely affected by many factors. We've done a lot better job of intervening upon acute myocardial infarction, post-infarction care in our CICUs, as well as the initiation and adherence to guideline-driven medical therapy. However, when you look at large epidemiological studies, we also see that risk factor prevalence is on the rise as well. ARIC, Cardia, Framingham, they all show that this data is true. And so whether it's the fact that we are intervening on a potentially fatal MI, ameliorating potentially fatal heart rhythms, and or just watching helplessly as risk prevalence begins to rise despite the community's best efforts. The fact is that our patients are living to deal with the sequelae of this significant disease and heart failure. And this hits home a little bit more. This is the 2004 data for coronary heart disease, age-adjusted death rates by state. And as you can see here in the Commonwealth, really we are in the hotbed. The darker the color, the more prevalent the disease process. And for me, having jumped from the frying pan and into the fire, you'll excuse my purchase of an elliptical machine this week. What really the reason is for me including this slide is that this presents the Herculean effort that is needed by practitioners and ancillary staff in taking care of this patient. But what it really does is place the onus on us in the research community to look for alternative options to better treat this disease entity. So let's get back to our index case then. His status post-surgical revascularization. His medical regimen is optimized. His risk factors are modified in that he's quit smoking 2 or 3 years previously. Glucose, heart rate, blood pressure, all fairly well controlled. Yet, he still has persistent symptoms. So the obvious question begs, what are his options? And so we know that definitive therapy for patients with heart failure is transplant. And over the years, what we've seen is that perhaps from 1985 to 1990, a significant improvement in surgical techniques better availed patients to this therapy. But over the last 20 years, it's fairly obvious, I'm sure you've been shown this several times, that donor organ availability is the limiting factor when it comes to patients being able to participate in this form of therapy. Beyond that, it's a very difficult process. You need for specialized medications, the need for specialized follow-up, and then of course there are unintended consequences, like we've seen with the previous vice president. Further treatment options, though, in all seriousness, mechanical circulatory support has been an amazing technological advance in the field of end-stage heart failure. But beyond the reaches of centers of expertise, such as University of Louisville, you know that a lot of our patients are falling through the cracks. Not to mention, this also comes with its burdens, driveline infections, GI bleeds, strokes, etc. So quite a commitment on those parts. When it comes to our patient, he wasn't really past that point of stability where he required such interventions, somewhere in the middle there. But so what is his option? You know, and the emergence of stem cell therapy really poses an alluring prospect for the treatment of patients with ischemic cardiomyopathy. It's a chance, in theory, to hit directly at the point of the problem. You have a scar. That loss of the myocardium is no longer creating the contractility that the ventricle once had, and loss of cardiac output. So we have a chance to get to the center of that and try to regenerate that tissue, essentially restoring pump function. But my question today is, over the last 10 to 13 years of clinical investigation, have we really provided any proof that cardiac regeneration is possible? And that's really my aim today, is to objectively explore the current body of evidence in order to effectively convey my vision for future direction of cell-based therapies in patients with cardiovascular disease. Greatest focus has been directed towards patients with acute myocardial infarction as well as chronic ischemic cardiomyopathy. And while there are trials out there in peripheral arterial disease, refractory angina, et cetera, that's beyond the scope of what we'll be discussing today. And to that end, really several cells have been studied, both extracardiac sources as well as intracardiac sources. And we'll try to quickly touch base on the majority of those. Let's quickly discuss some definitions of terms. Pluripotent cells are isolated from the blastocyst stage of fetal development. Pluripotency refers to the potential of these cells to assume a variety of fate transitions, meaning that this one cell can form tissue types of endodermal, ectodermal, or mesodermal lineage. Adult or tissue-specific stem cells stand further down the ladder of the lineage community, and they are multipotent or have a more limited repertoire of tissue types, phenotypes that they can assume. So embryonic stem cells would be a fairly quick discussion. We all understand the moral, biological concerns that come along with these stem cell populations. Biologically, the real concern is teratoma formation and or graft rejection. And teratoma formation, for those of you that remember the gene cell therapy trials of the 1990s, this is that harbinger. This is that one thing that really has zero tolerance. We cannot have that in the clinical trials of stem cell therapy, or that would halt progress almost indefinitely. So there's been great concern there, and as such, this form of therapy has shown effectively little promise in the way of clinical translation. One interesting concept, though, is induced pluripotent cells. Now, these cells were discovered in the lab of Dr. Yamanaka in Japan, 2006, for which he received the Nobel Prize in 2012. Essentially, he was able to reprogram rat fibroblasts into a state of pluripotency, which then, under the correct molecular environment, were able to differentiate into lineages of various tissue types of various lineages. This has been reperformed in human cells and currently serves as an excellent model for research processes. But unfortunately, these cells also carry a concern of tumorigenicity. And as such, to date, I'm unaware of any groups that are expressing intent for clinical translation. So let's switch gears a little bit. Pluripotent cells, not something that's really going to be clinically translated in the short term. Adult stem cells are a different variety. These are progenitor cells that can take on certain tissue type forms, but in the long run are not as widely available to take on different lineage as pluripotent are. And so for the treatment of cardiovascular disease, skeletal myoblasts were the first that were described. These are satellite cells that are recovered from skeletal muscular beds by biopsy in small numbers, which are expanded over time and are available for injection or infusion for the treatment of cardiovascular disease. And the first report came from Philippe Menachet out of France. What they did was they took a patient undergoing CABG, he had an EF of 21%, and they injected these cells epicardially around the area of the scar, followed him for 4 to 5 months, found that his ejection fraction improved to 30%, wall thickening increasing to 40% from negligible, and increased spontaneous viability by PET scan. Subsequently, they performed the MAGIC trial, 97 patients who were randomized to receive placebo, 400 or 800 million cells. They found no differences in cardiac function between groups at 6 months. And most importantly, this trial was stopped early because of the increased incidence of ventricular tachyarrhythmias in the treatment groups. The phase 2A trial was performed, the seismic trial, in which everyone was placed on amiodarone. But at this point, I think the majority of investigators from the community are convinced that these cells remain functionally and electrically isolated from most tissue due to the lack of important gap junctions such as connexin 43. Bone marrow-derived cells are the progenitors from which the cardiovascular research community has gained the greatest insight and experience through clinical investigation. And that's probably due to two reasons. Number one, there's a great deal of experience with bone marrow cells, as our brethren from the oncology side of the aisle can tell us. We've been using bone marrow transplant as a form of therapy since the early 1970s. And the other is that there's really no intensive ex vivo manipulation that's required. And to illustrate that fact, let's go back to the skeletal muscle biopsy. A biopsy produces a small amount of cells. Those have to be expanded, and that takes weeks to months. A single bone marrow aspiration can recover 50 milliliters and give you tens to hundreds of millions, which then by thick opaque density gradient centrifugation can be ready for clinical application within a matter of hours. So the first report was from the group of Dr. Strauer, and they looked at the infusion of 1 to 4 million bone marrow mononuclear cells in patients with infarction 5 to 9 days after the insult. And at a short time frame, about 4 months, they showed a small but statistically significant improvement in global and regional cardiac function. Importantly, the study demonstrated no significant differences in adverse events, and this was truly the springboard from which multiple trials were catapulted over the early part of the last decade. In the Top Care AMI, the Boost trial, as well as the Repair AMI trial. And it's a little bit of a busy slide, but there's a method to the madness here. In Top Care, it was an uncontrolled study where they looked at 20 patients treated with circulating progenitor cells or bone marrow-derived cells, and then they followed function out. And what they found was that the treated groups had about an 8.5% ejection fraction increase when you compare it to sex and age controls on an optimal medical therapy. Very impressive. The Boost trial was a trial of 60 patients, and this was a randomized trial. And in this randomized trial, they followed patients for 6 months. And at that time point, they found that treated versus control saw about a 6% increase in ejection fraction. Also a fairly impressive mark when you're talking about these types of trials. And then finally was the Repair AMI trial. This was a randomized placebo-controlled trial in which you can see that the treatment effect was really diminished when compared. So the importance of this slide is that with increasing rigor of clinical design, we have an inverse relationship as to treatment effect. And I think that's a theme that we have to take moving forward, and we'll discuss a little bit more. Now, this is compared against the negative trials that were performed. The STAMI is a trial of nearly 100 patients that over 6 months, there was no difference between ejection fraction between the groups. Furthermore, more recently, the CCTRN has come out with time and late time. These were trials of bone marrow-derived cells infused in patients either at 3 to 7 days after acute myocardial infarction or 2 to 3 weeks following myocardial infarction. And we saw no significant difference between those groups over that time frame. And finally, the trial from the previous page, the Boost trial, followed patients out to 18 months. And at that 18-month time frame, what they had found was that the treatment effect with the treated group and the improved ejection fraction from the control group basically made the changes that were seen previously negligible. So despite all of this, several meta-analyses have been performed, and like this one performed in 2006 here at the University of Louisville, showing that with bone marrow-derived cells, and taking all studies into account, that there still is a perceived improvement when it comes to left ventricular ejection fraction as an endpoint. Yes, modest, about 3 to 4%, but this was enough for several investigators in a multi-center, multinational trial that's now being performed in Europe to look at hard clinical endpoints. This is an event-driven outcome trial that will enroll a total of 3,000 patients to receive either bone marrow-derived cells or optimal medical therapy. that will be followed over a course of 1 to 2 years. Survival benefit, if that is demonstrated, would be adequate evidence for FDA support and approval. So within the next 3 to 5 years, we may actually see the first ever cell-based intervention approved for the treatment of patients with acute myocardial infarction. That's pretty exciting stuff, but of course, cautious optimism as to how the trial will play out. Now, improved selection techniques, excuse me 1 second. Improved selection techniques have allowed the investigation of subpopulations of bone marrow mononuclear cells, and I think that mesenchymal cells deserve special mention. These cells have been noted to have immunoprivilege. They lack the major histocompatibility class 2 antigens and have immunomodulatory effects. And as such, they have been tested in the clinical arena as one single donor being able to provide for several recipients. And that creates a very unique perspective for treatment of acute myocardial infarction as an off-the-shelf type of product. Furthermore, CD133 positive cells, CD334 positive cells have all been studied in acute myocardial infarction. And really, the treatment effect is no more than that which we saw for bone marrow-derived cells. So it kind of begs the obvious question. We are using all of these extracardiac progenitor cells to try to treat this organ-specific disease process. Is there, in a perfect world, a progenitor cell from that tissue compartment that we can use to treat these processes? And that the notion as to whether or not the heart is a post-mitotic organ in postnatal life has been really challenged over the past decade. Some early studies of post-mortem analysis on sex mismatched transplant recipients did suggest that there was newly formed cardiomyocytes in the human heart, and this was subsequently confirmed in a very elegant study by the Bergman group. It was published in Science in 2009, at which they looked at populations of people who lived in and around in proximity to above ground nuclear testing. So they were able to use those atmospheric increases in carbon-14 to carbon date the nuclei of cardiomyocytes in postmortem analysis and get a roundabout idea of age of cardiomyocyte. And their perspective was that through mathematical modeling, the lifetime of a human organism, we have about 50% turnover of cardiomyocytes. So this drove research, and at the laboratory of Dr. Piero Anversa from the Brigham and Women's Hospital, there was extensive publication on the existence of a stem cell isolated from the cardiac tissue of several species, including humans. These cells are marked by the tyrosine kinase receptor c-KIT. They exhibit properties of stem cell populations in that they're self-renewing, clonogenic, and multipotent, or able to demonstrate markers of cardiovascular lineage in vitro and in vivo. These cells have robust replicative potential, and they also show excellent telomerase activity as well as telomere length and a paucity of cellular markers. So this helped us move forward in the conceptualization of the Scipio trial, which conceptualized in 2004, approved in 2008, and the first patient was enrolled and treated by middle of the year in 2009. As of 2011, 20 patients have been infused and 13 controls have been followed up. Scipio, basically, I know that you've heard some details about the trial. Enrollment was at 2 times. Eligibility, initial eligibility was determined at 2 weeks prior to CABG, and if patients were eligible and agreed to be enrolled initially in the trial, then the right atrial appendage was biopsied at the time of CABG surgery, and cells were isolated and grown out over the next 4 months. At 4 months, a repeat reevaluation of the inclusion and exclusion criteria. And the reason at 4 months was that this was a generally accepted time for recovery of hibernating myocardium, so that if that depression of ventricular function was still there at that time, that it was accepted that that would be essentially a permanent condition. So furthermore, those patients who were allocated to the treatment arm did undergo infusion of up to 1 million stem cells through balloon-inflated catheters into the region of infarction. After that infusion of stem cells, they were followed out over the next 2 years with a host of testing to mostly look at safety, but some measures to try to attain preliminary efficacy data. Enrollment was quite a task. There were over 1,545 patients that were enrolled, 98 that met criteria and agreed to participate. Secondary enrollment points took place for Stage A and Stage B. Stage A was a run-in phase, since this was a first-in-human trial. Short-term safety was the initial data point for the DSMB. And then ultimately patients were randomized either to treatment or control in a block randomization fashion, followed over 2 years, until we did have 20 treated, 13 controls. But looking back to that original number of 1,500, that was only 2.1%. So you can see the feasibility of performing a trial, a larger trial, with only surgical candidates is essentially impossible. And now we modified our ability to extract cells through endomyocardial biopsies and can avail this. And as you know, the heart failure population, generally not many of them require repeat open heart surgery. So this is a big movement forward for us. With the 3D echo results, looking at the treated patients, 2 were excluded initially, 1 because of uncorrected aortic stenosis, and a second because of poor image quality. At the 12-month time point, 1 patient was excluded because he did receive 5 ventricular pacing, which in and of itself has been shown to increase ejection fraction. And at the 15-month time point, the 24-month time point, we lost 2 to follow-up. So essentially, we have 15 treated patients that are included in the functional analysis. And what we saw was that steady increase over time. But this is really the relationship that we see. Over that first initial infusion, we see a pretty significant improvement, and that remains stable over time. I think that's really going to be the theme of the majority of these data that I present today. So when we look at them side by side, what we see is that indeed the treatment group for the 15 that were included in this analysis did have an increase of approximately 9 absolute ejection fraction units, whereas the control group only showed approximately 3% increase, which was non-significant. I didn't think that was going to play. Unfortunately, this is one movie that I had a little difficulty getting to play, but we did also have MRI analysis for a subgroup. And amazingly, when you look at ejection fraction for the patients that were included in that, and remember, a host of patients were not included in MRI analysis because at the time that of conceptualization of the trial, it was not as well accepted that devices were safe to go MRI. So now we know a little bit better, and I think that practice is becoming a little more widespread. But if you look at the trend in the numbers, it's amazingly similar. Whereas at 24 months, for those patients that did MRI, approximately a 9.6 increase in absolute. We also looked at scar mass by several methods, either full width half maximum or manual delineation. And this was done in collaboration with our partners over at Johns Hopkins Medical Institute. And what we saw was that over time, the decrease in scar mass was significant, coming down from about 34.9 grams to about 26 grams, remaining fairly sustained over that 24-month period. New York Heart Association functional class, similar, no improvements in the control group as well as a sustained improvement in the treated group, and also with the Minnesota living with heart failure questionnaire, the quality of life remained about the same statistically for the control group and improved significantly for the treatment group. Most importantly, this is a phase 1 open-label trial, and the point of a phase 1 trial is to look at safety data. And as you can see here, we saw no significant differences in adverse events when it came to the group. So, in conclusion, the initial results of CIVIO suggest that in patients with ischemic heart disease, infusion of CK-positive stem cells is not only feasible, but safe and produces a sustained improvement in LV ejection fraction, functional status, quality of life, as well as sustained reduction in infarct size. And then the discussion would not be complete about resident cardiac cells if we did not discuss Dr. Marban's work. So in 2004, reports from his laboratory were of stem cell clusters that were spontaneously emanating in cultural medium from biopsies and forming spheroid structures in suspension. The cells were found to be a heterogeneous collection of cells with physiological attributes of stem cells and markers similar to CK-positive cells, as well as mesenchymal stem cells, or CD90 and CD105. Favorable preclinical data led to the performance of the Caduceus trial, which was concluded in 2012 when he reported on 17 treated patients and 8 controls. They saw no difference in ejection fraction or in chamber sizes, but did note a significant reduction in scar size, which the authors attributed to proof of cardiac regeneration. So that is a good segue into where are we now? And the first question I'll ask is about that last comment I made from the Caduceus trial. Is transdifferentiation the sole mechanism by which stem cells exert clinical benefit? Meaning, are we regrowing heart muscle? And that's the reason that we're seeing positive outcomes in these trials. And I would caution you on that statement. Cell retention data is far from encouraging. Hours to days after treatment, cells within animal models are at fractions of the cells that were infused. And if you look at them about a month out from treatment, they are essentially negligible, non-existent. So thereby, it's nearly impossible to ascribe the improved cardiac function seen in these models to regeneration alone. Furthermore, I think newly formed myocytes that have been seen in vitro experiments don't really assume that mature cardiomyocyte phenotype that we would be expecting would contribute to these improved parameters or metrics of cardiac function. So then what mechanism is postulated? Well, it's been shown in several in vitro studies that paracrine stimulation is likely the significant mechanism that's involved here. These cells secrete trophic factors such as insulin-like growth factor, hepatic growth factor, SDF1, VEGF, and these molecules exert anti-apoptotic effects, angiogenic as well as chemotactic effects. Postulated effects also are that the endogenous group is recruited by the infusion of these cells to differentiate as well as continue with a sustained release of paracrine factors. There is some evidence that cardiomyocytes can re-enter the cell cycle, albeit at low levels, to provide some cardiac regeneration, and some other evidence, postulation that epicardial cells, there are progenitors within that layer that can also contribute to differentiation. So at this point, I don't think it's possible to use the R word too loosely, but that will be the point of future trials. Other lessons learned is don't believe the hype. We see these articles every day in the paper, and the clear message from the trials being performed to date is that preliminary efficacy data has not translated into large clinical benefit once you've employed more rigorous clinical trial design. Matter of fact, with the exception of repair AMI at 24-month follow-up, initial effect or difference between groups was essentially negligible at time points further from the point of treatment. So I'd like to say that let's remember this efficacy data is based on small cohorts. And the purpose of these phase 1, even phase 1-2 trials is to demonstrate safety. But at the same time, we're looking at preliminary efficacy data, even in the negative trials, based on one single treatment. And do we give one pill to patients with pneumonia and say, well, you're going to be fine tomorrow? You know, treatment at different time points may be one of the potential strategies that we can use. Obviously, owing to safety data, we need further investigation. So this and questions like this have led to identification of several concerns that really must be addressed in future clinical investigations. What are the optimal cell types? Well, obviously, we've not seen a magic bullet yet. Whether that's a resident cardiac stem cell population or another progenitor that is engineered, we don't know that yet, but further investigation is certainly warranted. What's the optimal cell dose? Well, I mean, with work from the hair laboratory, with the primal cells, we've seen escalating doses. And you know, they tried 20 million, 100 million, 200 million cells with the mesenchymal stem cell population and found that the 200 million injection did no better than the 20 million. So we also need dose escalating studies. Frequency of treatment, as I just suggested, perhaps frequent dosing could be one option, and as well as the optimal route of cell administration. Now, we use intracoronary infusion. Many cell trials today are using intramyocardial injection with a catheter-based syringe, catheter electron catheter mapping the ventricle to know where the scar is and inject in the border zone of the scar. There is some data to suggest that that is better, but if you look at the only phase 3 trial, which I showed you before, BAMI, they are using intracoronary infusion. So the data is not convincing, and I think that we need more study in that area. And then, of course, what are the optimal clinical endpoints to determine therapeutic success? Left ventricular ejection fraction as a measure has been highly debated. And I think as we come forward with better imaging techniques, such as T1 mapping with MRI, metabolism studies, potentially the infusion of PET imaging into our stem cell studies, albeit that can be financially infeasible, but we need better endpoints and in order to determine therapeutic success. So what are we doing here at the University of Louisville? I think it's an opportune time for us to transition into discussion of what's going on in the future of stem cell therapy, especially what's happening here. And so I think we have time for a quick funny story. I got that phone call in March of 2011 from Dr. Bowley, and he said, "Did you see my email?" I said, "No, I'll open up right now." And he said, "Do you know what this CCTRN thing is?" I said, "Yeah, I've heard of it. They did focus and time and late time, you know, very organized, well thought out studies and well executed." And he said, "Okay, I want to apply." And I said, "Oh," and then I looked very closely because I said, "This grant is due in 30 days. He said, "I know." Click. Needless to say, 30 days later, with the help of Steve Jones, Rudy Bhatnagar, and Samant Prabhu, who was here at the time, the grant was done. 6 months later, we were accepted as one of the only 7 centers that are involved in this network of physicians, scientists, and ancillary staff that are funded by the NIH in order to complete clinical investigation into cardiovascular disease and disseminate that information reliably and quickly within the healthcare community. So looking at the structure, I mean, you've heard Dr. Bowley refer to Scipio's garage trial. You know, there was really only a very limited few of us who were able to help perform that trial. Well, this is like the kid reading in the candy store. This is absolutely beautiful organizational structure. The review committee, ESMD, centralized steering committee, centralized data coordinating center. There's protocol development committees, publication committees, cell processing core, biorepository support, and imaging cores. So essentially, everything that one would need to forward with the clinical trials of stem cell therapy. Excuse me. And so I'll take a minute to infuse a shameless plug. We are doing a trial of peripheral arterial disease called the PACE trial. It's for patients with intermittent claudication who either want to stave off surgery or avoid it altogether. If any of you, I know we all have these patients coming into our clinics. Any of you have a patient who meets that criteria, all I need is a phone call, and we'll have someone down there to talk with them and try to see whether or not we can help them out through that situation. But I really just wanted to concentrate on the CONCERT HF trial, as this is our transition and maturation of clinical investigation of c-Kit cells. So CONCERT HF is, as we see here, a combination of c-Kit and mesenchymal stem cells, novel dual cell study evaluating regenerative properties in the treatment of heart failure. The study rationale basically will test the hypothesis that safety and feasibility of administering KIT cells in combination with MSCs for the treatment of ischemic cardiomyopathy. And the concept was born out of the laboratory of Dr. Hare at Miami, where he used combination of cells compared against KIT alone, MSC alone, or placebo, and found that they saw a marked increase in left ventricular ejection fraction. That data is not shown here, but a significant decrease in scar size as well as scar mass. So moving forward, this is the proposed study design. I apologize. I realized this when I first got here this morning, that this only looks as if there's really 2 arms there, but there will be 4 arms here with 20 patients each. We will look at, as I said, placebo versus KIT alone versus MSC alone versus combination of the 2. We will follow them out 6 and 12 months and see mostly what that safety data is this is a first-in-human study, but also look at some preliminary efficacy data. These are busy slides. I'll summarize. Primary endpoints will include safety measures such as MACE, as well as other adverse and serious adverse events. Primary endpoints will also include measures of feasibility, and that's the point of the phase 1 trial. Looking at secondary endpoints, we will include metrics of cardiac function, the CMR, as well as functional status and quality of life questionnaires. So in summary, this phase 1 approach will look at safety and feasibility of this first-in-human combination therapy and preliminary efficacy data in order to plan for future clinical investigations. And I always keep this acknowledgement up there, discussing the fact that we do receive funding from the NIH for management of these clinical trials. So let's get back to our case presentation. Michael Jones, I'm allowed to use his name. He's given me permission. He's been on every major news network in the country, so most people know who he is if you followed the Scipio saga. This is him with Dr. Bowley at 7 days post-transplantation, and this is him with I am Dr. Ikram, his 24-month evaluation. Now, Mike's story is super interesting. He told me that the 18 months prior to CABG, he had probably ingested 1,000 nitroglycerin pills. I said, that's impossible. He showed me his reorder. It was amazing. After CABG, he did get some relief. He said he was probably down to like 5 to 10 a week. But beyond that, he has only taken 2 to 3 per year since he was infused with KIT-positive cells. So, you know, a really amazing story for a really amazing guy. He does what he wants now. When he started, as we said, he was ejection fraction of 26%. Over the time points, we saw him rise to ejection fraction of 40%. Matter of fact, I did TE on him to VA a little while back, and he's still around 40 to 45%. So instead of following that normal natural course, that trajectory of downward slide, just ventricular modeling, this gentleman has actually gotten a little bit better. But as I said previously, let's approach these phase 1 studies with cautious optimism and not irrational exuberance, because it's really important. And it's important that we address all of the questions that I talked about before. In summary, you know, multiple small-scale trials have been performed with conflicting results, but larger prospective trials are important in investigating durable clinical endpoints and their wellness. Rigorous classification of subsets likely to benefit most from cell therapy is needed. I didn't get to talk about this, but I think that when you look at the organizational structure of the CCTRN, that this is crucial. We have all of these cells, we have all of these patients' information. We should be able to, as time goes on, look at the demographics, the comorbidities, all of the issues surrounding these patients, and find out whether or not we can develop some type of competency index to say, you will respond to therapy, you will probably not respond to therapy. What we've learned from that biorepository of the CCTRN over its first iteration was that some of the bone marrow mononuclear cells that were infused had varying compositions of things like CD133 and CD34. Those who had higher compositions tended to do better. Older individuals tended not to do better. Patients with worse ejection fraction tended to do better. So we need to look at these clinical factors and combine this into some type of algorithm where we can somewhat predict how well you will respond to stem cell therapy. Furthermore, optimization of all the factors like stem cell dosing, type, frequency, and route of administration. These need to be short-term goals for future clinical investigation. Definitions of acceptable clinical endpoints to define therapeutic success. I think that's paramount as well. And as I said, as we develop better techniques with cardiac MR, cell tagging, other issues, I think that we will come up with better parameters. So I'd like to thank everyone here at the University of Louisville who's participated, as well as our Johns Hopkins collaborators at the Christ Medical Center have also helped with recruitment in the Scipio trial, of course, the steering committee members of the CCTRN. That's all I have for today, so if you have to answer any questions.
Your proclivity for public speaking did you well today. That was very good. I was impressed with your slide, which is a very similar slide for lung transplantation of about 2,000 plus. Yeah. Heart transplants a year, yet 1 in every 3 dying of disease, and there's tremendous gap of people who will never have the opportunity for having a heart transplant. No, and that's why this is one of these things. I wanted to ask you, because one of the issues that we in the lung world that we're struggling with is clinically significant improvement as opposed to statistically significant improvement. So for ejection fraction, what is the percent that you feel comfortable that if it's increased, it truly has an impact on the patient?
It's a very difficult question to answer. I think that inter-observer variability is somewhere along the lines of 5% when evaluating inter and even intra-observer variability. So ejection fraction may not be that best endpoint that we need to determine therapeutic success. I think metabolism is one of those things, and cardiac PET is such a great tool. It's so expensive, so little expertise in regions, so difficult to standardize that as well. I think that as we move forward with perfusion type of imaging, with cardiac MR, as far as T1 mapping, etc., more than just late gathering enhancement, because there are inherent flaws with enhancement, that we will further define and tweak those endpoints to see what we need to do. Because even when you look at functional parameters, if I took a whip to your back for 6 minutes and walked you around with an oxygen saturation monitor on, I might be able to get you up to 30.
Oh, you will.
But if I didn't have my coffee that morning, I might not be able to whip you those extra 30 minutes. So there are problems there, and we are desperately working to hash that out.
Questions?
Thank you so much, John. I just had a question to follow up with Dr. Roman's question. And, I wonder if, about the endpoint as well, and you mentioned functional status, and doesn't it make the most sense to measure what the impact is on the patient's quality of life and their functionality, their performance status? I've looked at the Minnesota Quality of Life questionnaire, and I found some gaps in it. I mean, could we come up with a better tool to measure quality of life and do a better job of evaluating that at baseline, and perhaps take in not only the patient's self-assessment, but also those around them to get a more accurate sort of read on that?
I think that's another great question, and of course there are other questionnaires like Seattle, heart failure as well. They are somewhat objective, but in a blinded fashion, in a truly blinded control where Scipio was open label, they knew that they got their cells, that perhaps those would be more effective. But I think it's another area where we need to work harder in order to come up with some type of functional assessment that's less subjective and determines more in the way of therapeutic success. So I think it's a collaborative effort between people who see this every day, like yourself, and see what clinical markers we can look at in quality of life.
I know when the Scipio trial was started, you only did ischemic cardiomyopathy because the cabbage was part of the harvesting process. Now that you're harvesting the catheter sampling or what have you, are there any animals models yet or any soon to develop non-ischemic cardiomyopathy transplant trials?
That's a great question as well. So there is a bovine model through the Cardiovascular Innovative Institute, through the Surgical Institute, where they use microspheres that are infused down the coronaries and create essentially a global cardiomyopathy. I won't say it's non-ischemic because when you occlude arteries, it's ischemic, but they look at that global model, and they're using that mostly for LVAD implantation and looks there. Clinically, we have looked at some studies. So there's Top Care CHD, there's Top Care DCM, looking at dilated cardiomyopathy, and those results have not been as encouraging. That's not to say that cell therapy could not be beneficial, and there are several studies that are planned, especially for patients with LVADs, and trying to get them to recover and off of mechanical support. But again, a difficult population, the points for clinical success are not thoroughly defined at this point.
John, there are, you want to say something, sir?
Yeah, we just want to add, there has been a very good study of CD34 cells in patients with idiopathic dilated cardiomyopathy by Vetrovec, at Stanford. It was a joint Stanford-Croatia study. Anyway, and it was a very positive study with a 5-year follow-up showing the sustained improvement in cardiac function and in clinical outcome in these patients. It was not very large, I think it was only 50, 60 patients, but it was encouraging.
So John, there are people in this audience who knew you when you were sitting back there, and I want to tell you that they're very proud that they have seen you now move onto the stage and how you have evolved into an academician and a clinician investigator, which is terrific. So because we're proud of you, I usually save the tough questions for those people. So here's a question that we might not be able to finish today. In fact, I won't. But having developed gray hair over time and being around quite some time, I've learned that there are great ideas that it's just very difficult to let go of. And we spend decades trying to let go of a great idea and billions of dollars. Gene therapy was an example of that, and we're still working at it. What do you think is going to happen? What does your gut tell you about stem cell therapy? Because there are multiple areas in which we now probably feel comfortable that stem cells are not going to work. This one is still we're working on. You did a great job at providing a balanced discussion of all the negative and positive. When is a great idea worth letting go?
It's a very difficult question. Obviously, we still see some signal, and there is still, in my mind, enough evidence to move forward. I think that the BAMI trial, if negative, may put a significant damper on future investigative efforts. There are so many things that may also determine the fate of clinical translation, and one of that is really being the business model. If you're looking at autologous cells, where they have to be expanded individual incubators, all of that labor-intensive movement. In a lot of places, a lot of businesses will be scared by that because what will you recuperate? So I think I do think that in the short term, the family will play a large role in how much effort is continued to be put into clinical trials for stem cell therapy. But my personal opinion is if there's a signal there, we should look for it. However, at some point you have to say this is just incremental and not better than medical therapy. But we've had stem cells. No.
Yeah, no. This is good. I will finish by saying my father, who developed a severe heart attack some years ago and now has congestive heart failure, has Roy Taboli's phone number on his refrigerator, sending my phone call to say, come over, we're ready for you. We're expecting good things from you. Thank you.
Absolutely.